Hi, everyone. My name is Ellen Evans, and I am an assistant professor of music therapy at the University of Georgia, as well as a fellow for the National Institute of Infant and Child Medical Music Therapy. And I'm so happy to be speaking with you all today and happy to be here with my colleague, CL.
Hi, everyone. My name is CL Knox. I serve as the Medical Music Therapy Director at Tallahassee Memorial Healthcare, which is a collaborative program with Florida State University. And I'm also happy to be a NICU Institute Fellow, as well as serving as their training coordinator. So excited to be with you all today.
Today, we're going to talk a little bit about understanding typical and atypical development in infancy and early childhood, and why that is important to understand for early intervention practices. A lot of us, when we were in school, we got training on working with exceptional children, but a lot of that training focused on after a formal diagnosis is made. That normally doesn't happen until about 3 years of age. And a lot of development happens before that. And it's actually a very critical window of development before 3 years of age, with over 1,000 trillion neuroconnections being made before 3 years of age. So we just want to highlight this critical period and talk a little bit about typical and atypical development to give you a better understanding of what you can do as a music therapist, as a music educator, but also how that might impact you when you do see them maybe in childhood or even as adults. It's important to have this understanding and foundation. So let's talk a little bit about early development. So I've got a chart here for you because we really want to hone in on the sensory system. Oftentimes when we think about development, we think about things that happen after birth, but there's a whole critical amount of development that's happening while the infant is still in the womb, especially with the sensory system. So as you can see, all of these sensory systems are formed, as well as we are seeing cortical responses on different neuroscience techniques like ERP before the baby is born. So in that third trimester, we are seeing that baby using those senses already. So this is important to remember as we're working with them. And this is the foundation that these infants need in order to then gain and build on further in their development. So again, like we said, the development of these sensory processing abilities is necessary for them to be able to then have higher order functions that happen in early childhood. But it's also important to remember that these senses develop through input and experiences. While the infant is in the womb, they are getting input and experiences that are helping these senses to develop. But this also happens after they are born in early childhood. And so it's important to continue to have those experiences to continue to develop those senses. And then having these senses then further drives play and engagement with the world around them. So it's almost like it's a whole circle of a process. And so they have to have input and experiences to develop the senses, but then the senses further their play and engagement with the world around them. But then that also still continues to build their senses. So it's almost like a cycle that's happening. And children have always played and engaged with the world around them. Even back in hunter-gatherer days, we have evidence that children played and engaged with the world around them, and that's often how they developed in early childhood. So what we found when we look at what's happening in the home environment, children are engaging with objects in their home, and it's often for a short period of time, and they're interacting with a lot of different objects for short amounts of time, but it actually consumes the majority of their time. Over 60% of the infant's time at home is spent engaging with objects and engaging with their environment. So this play and engagement with objects by seeing them, hearing them, and doing things with these objects further develops the development of in all of the areas of domains. So whether that's fine motor skills, like using pincer grasper skills, gross motor skills, like crawling, holding their head up, trunk control, expressive communication, babbling and talking, receptive communication, understanding language input and using it purposefully, whether that's adaptive behaviors, so being able to start working on all those skills that are going to be needed for activities of daily living, or whether it's also social and engagement skills. Those are all important. But what's important to remember is that we need quality and quantity of interactions in order to drive neurologic development. So we want them to have the variety of different interactions that they're having, but we also want those interactions to be quality interactions. So oftentimes we need a caregiver, a parent, or some sort of person that's there to help them and support the interactions that they're having to take it to that next step to really help drive that early neurologic development. So we want quality and quantity. But now we want to talk a little bit about some factors that often impact early development, because there are some things that can make us watch a child more closely in their development in the early years to make sure that they might not have atypical development. And the first thing is the impact of NICU hospitalization. And the research is showing now that it's not just being born preterm, but any infant that spends time in the NICU, because of the environment that they're in, it is playing a role in their early childhood development. And so this is what this graph is showing you. So you've got the baby's brain, the neonatal brain. It could be born premature, and so it's dealing with that. There's a lot of growth happening in that time period. There's a lot of plasticity in the brain. There may or may not be injury to the neonate's brain. And then the neonatal brain is trying to then work on continuing to develop those motor systems as well as those sensory systems, which we know interact and interplay with each other from our previous slide. But then these systems are also working on beginnings of behavior, communication, and cognition. So all of that is happening while natural maturation is happening of the infant. So naturally getting older, naturally having some things happen, but while they're also having very abnormal experiences in the NICU compared to the experiences of being at home. And so these experiences, along with this maturation, are both impacting how the neonatal brain is able to develop those sensory systems and motor systems that then affects behavior, communication, and cognition. So specifically, when we took a look at the sensory systems that are impacted, the tactile system is impacted. And what research has shown is that the more painful procedures that infants have when they're in the NICU, the more they think that touch, skin to skin contact is painful. The other thing that we see is that visual system is one of the last ones to fully develop. And so it is still developing while the infants are in the NICU. And so that's why we oftentimes will cycle the lighting to attempt to help with that visual development. But that's also why we need to also watch to make sure we're not causing any harm, because if an infant's on too much oxygen, they'll develop what's called retinopathy of prematurity, where the retina can detach from the eye. And so when we see that happening, sometimes we'll do surgery to try to correct that and to try to help that. But oftentimes they might have some sort of visual impairment that might require glasses in early childhood. The other thing that's really important for us to understand as musicians is that auditory system. And so the womb naturally protects the speech sound that's being allowed into the baby as they're developing, allowing the appropriate amount, the appropriate pitches, and all of the things naturally. But it's not happening that way in the NICU. And so in the top picture, you have a picture of a single patient room where you see the nurse's speech sound is being deflected off of the isolette. And it's not actually getting into the isolette where the baby is, but all of that machine noise from the alarms and things like that in the room is getting through the isolette. So they're actually having a deficit of appropriate speech sound, which we've actually found to be just as damaging neurologically as having too much sound. So we've actually found previously we thought too much sound was too bad, which is that bottom picture where you've got all the people talking and all the machine noise, and it's all kind of coming together where they're not hearing speech sound. And we could all agree, yeah, that was bad. So we put all of these infants in single patient rooms. And then we found out, well, if they're not getting appropriate speech sound there either, we're also seeing the same adverse effects on their neurologic development in their speech and language skills in early childhood. So those are things that we found, but we found that if we can then get appropriate speech sound and have more maternal involvement in those single patient rooms, that we can try to overcome some of those deficits. So there are some things that we can do to work on that. Let's talk a few minutes about medical complications at birth. We just want to make sure that you understand these diagnoses and what you could be seeing and how that could be impacting their development. So the first thing is brain injuries, and we have IVH, PVL, and HIE, which is grades 1 through 4 for IVH, with 4 being more severe, which you can see in the picture. That's a larger brain bleed for IVH 3 and 4. So what we found is that it depends on the severity and the location of the injury in the brain, what those long-term impacts might be, but we're typically watching for motor delays and cognitive impairments. Oftentimes, specifically with IVH 3 and 4 and PVL, we're really watching out for cerebral palsy. And that's why we will watch the infant's movement and how they're moving in early childhood to try to catch and detect any sort of early signs that might be something that we need to be working on. So with brain injuries, we're often looking at those motor and cognitive skills. When it comes to respiratory diagnoses, the first thing is respiratory distress syndrome. And that is where they don't have enough surfactant as an infant to keep the alveoli expanded, so they collapse. And what we found is that they might have chronic breathing problems like asthma into early childhood. And then that can affect their movement and their learning, and they might have some behavior problems. And then when we look at bronchopulmonary dysplasia, which is where we've actually caused damage to the alveoli by using ventilators to inflate the lungs, and then with that inflation and then them exhaling, we create scar tissue. So that scar tissue makes it hard for these infants to exhale, and that scar tissue has to heal. So what we found with them is that they actually might develop hypertension that persists into adulthood. And we've seen some lower cognitive and language and motor skills at 18 and 24 months of age. And with both of these, what we see is that the lungs and their respiratory system is impacted, which then impacts their ability to explore and engage with that environment that's around them. And that's commonly what we're seeing as the reasons, the possible reasons for why we're seeing these lower scores where we're seeing them. One thing to remember about cardiac diagnoses is that it's normally that they're at a risk for developmental delay, but not necessarily due to the diagnosis itself, but really more on the amount of time they're spending in the hospital and the amount of surgery procedures that they're having. Because as we already have talked about with NICU infants, the hospital is an abnormal environment for kids where they really can't get down and explore and touch all of the objects in the environment and really have those sensory experiences. And so really it's that amount of time in the hospital that can affect the developmental outcomes for kids with cardiac diagnoses.
And next, we're going to move into just how exposure to substances in utero can impact development. And some of these infants might be hospitalized if they have a lot of symptoms at birth. However, a lot of them are not often caught at birth that these things have been exposed in utero. So a lot of times we see a lot of misdiagnoses with these children. Just kind of reviewing some of what those substances might be. We have alcohol exposure, which is known as fetal alcohol spectrum disorder, opiate exposure, which with the opiate crisis has been, an issue that we have faced in hospitals. And there are two names for that: neonatal abstinence syndrome, or NAS, and NOWS, which is neonate opiate withdrawal syndrome. So those are two names that you might hear. Nicotine exposure can also lead to some atypical development, as well as THC and cocaine exposure. And we'll tell you what those outcomes look like. So overall, a lot of these have some crossover, but there are some specifics within each of them that present themselves a little bit differently. So with alcohol, you might see some delayed cognitive, behavioral, health, and adaptive functioning, as well as just overall learning difficulties if they've been exposed to alcohol in utero. For opiates, we see hyperactivity, memory and perceptual problems, delaying cognitive, adaptive, and social skills. This is also an area that it's been hard to have longitudinal studies, so we're still constantly learning more and more about this population and the long-term outcomes that these children encounter. With nicotine, oftentimes children have impulsivity and attention problems. Hyperactivity, this is one that is oftentimes very misdiagnosed. Negative externalizing behavior and social issues. There might be some physical abnormalities with muscle tone or oral facial cleft. And then when we think about THC, there's oftentimes inattention and impulsivity involved with that if they've been exposed in utero. And cocaine, we see behavioral problems, attention disorder, and oppositional defiant disorder. So just an overview of what some of the long-term outcomes could be. And that brings us also into childhood trauma. So 46% of children have experienced at least one adverse childhood experience. That is a huge population of children that we are talking about. And this is specifically within the United States, but internationally, children have experienced a lot of childhood trauma as well. And this is actually one of our biggest public health issues that cost our healthcare systems a lot of money, that is also oftentimes not going noticed. So what is an adverse childhood experience? It can be defined as abuse, neglect, or any household dysfunction that the child might encounter. So we're going to go into the next page of just what some of that might look like and how there are short-term outcomes of what that might look like, but a lot of long-term outcomes as well. So overall, children might have skewed beliefs about themselves, their caregivers and the world around them. They don't often know how to interact, what appropriate boundaries are, because they've never been given that model or that example. Oftentimes they suffer from post-traumatic stress disorder, which encompasses anxiety, depression, fear, problems sleeping, which we know when dealing with retention of information or processing information is heavily skewed. Social and behavioral issues, anger management, attention problems, and then just long-term health complications, which can oftentimes impact their ability to remain engaged in the activities that we're presenting with them, because they might have to be out for reasons. So a lot of different outcomes that can impact overall their development and engagement with the world.
So now we're going to talk a little bit about how all of this information about their development should help guide us in early intervention. So the first thing I want to briefly touch on is assessment in early childhood. Assessment is great, and it is one of the greatest tools that you can use. So down in the visual, you can see two assessments that are commonly used. And one is the Bailey Scales of Infant Toddler Development, as well as the DACY. Those are two that you might see. And what I also just want to remind you is that oftentimes a diagnosis is not made till 3 years of age, but we're still doing these assessments to try to see if there are any developmental delays. And we'll give them kind of the developmental delay diagnosis so we continue to get them services and continue to get them those early intervention needs that they have prior to a diagnosis being given later in childhood. So when you're looking at these assessments, they can give you a lot of information. The first thing that you want to look at is the time to mastery of these developmental skills. So you want to see, is their developmental age, what these assessments are saying their developmental age is it the same thing as their chronologic age, or are we off? Is it a little bit different? Also, we do these sequentially over time. So look at the 6-month assessment and then look at the year assessment and how many skills were being developed between those two assessments. Did they make a lot of gains? Or did we see even less gains? And almost the gap between development and chronologic age is even more. So what's happening there between assessments? You also want to look at the quantity of the developmental skills. How many skills were they observed doing overall? But were there specific domains where you can already see the skills that they're developing are a lot less than in other areas? So maybe they might have a lot less motor skills and they have communication skills, or their receptive skills look good, but their expressive communication skills are not looking as good. So look at the different domains as well. Also, this can look at the quality of those developmental skills. Is it consistent? Are they accurate in all of these skills that they're doing? So the way that these assessments work is they look at that chronologic steps that are taken in each domain for development, and development happens in steps. So it's really important to remember that. And so using these and what they're looking at these different age stages can actually help break down developmental steps for you. So yes, it's important to know about the child, but in general, if you want to learn more about development, the way these assessments break down each developmental domain and each step and task that it takes to build development is really great to look at as a tool for learning more about development.
And when we're thinking about these assessments, oftentimes these assessments are taking place, maybe in the classroom or a therapy gym, where there's a lot of different resources that we can pull from to see how the infant or child engages with their surroundings and their environment. So it might look with like a lot of colors, a lot of items, but in reality, if we go to the next slide, we can see that oftentimes this is not what the child's home setting looks like. Not that this is the home setting of every child, but oftentimes there's TV. We know the debate about screen time. Parents come home, they're tired. Who knows how often they're home or not home? So what's really important to consider when doing these assessments is, what is this child going home to every day? What's in their environment? What is accessible to them? So that way we can engage and interact with parents. And the literature actually shows that it's not the items with all the bells and whistles, all of the, developmentally approved toys that are the key to success. No, it's actually more about that engagement and interaction with the caregiver and showing and utilizing how an object is used. Even if it's a water bottle, if you screw on and off that cap, the infant or child observing and learning what the purpose of it is and what they're supposed to do, what their interaction and purpose is much more important and beneficial long-term than all of the items that are actually there. So we're going to talk a little bit about how to engage with parents and how to coach them in these things.
Yeah. So what the research has shown is that it's shown to improve development, especially in communication and social skills when we partner with parents and we use more of a coaching model. So if we can consider ourselves, yes, as music therapists and yes, as music educators, but really we are there to support parents and to coach parents. And that improves the child's development by us doing that. The Department of Early Childhood actually emphasizes supporting caregiver child interactions in everyday routines and using family capacity building approaches and activities. Those are some standards that they've kind of set for all early childhood intervention, is that we should always be working on those caregiver child interactions and working on building the capacity for them to do that in activities. Also, ASHA and the Association for Occupational Therapists state that coaching caregivers is an important service delivery model and is something that we should all be doing. How we do this, we want to develop child-oriented skills. So you need to keep your child-oriented skills of being able to observe behavior, observe assessment, have an understanding and a really deep knowledge of child development. You want to be really fluent in your evidence-based practice so that you can address multiple developmental domains. So you need to know a lot of things about how to address all the different domains, not just motor, not just communication. And that's because a lot of things and activities that we do cross multiple different domains, especially in music. You want to develop your adult oriented coaching skills too, so that you can guide and direct their interactions and make it so that you're not talking to them like you're still talking to the kid. You want to develop those adult oriented coaching skills. You want to help these families identify their priorities. What's a priority for the family? Not just a priority for you, but what's the priority for the family? And you want to understand and explain child learning and development in family routines. They might not know that them using a water bottle at home is a learning opportunity for their child. So you want to make sure that they know that. And you want to discuss the strategies and interventions, including when to implement them, not just do this, but when should we do this? And you also want to make sure you include the why. The families need to know the why of what they're doing and why it's important for their child. We need to reset our baseline that all parents want their children to succeed and they really do want to help. And so make sure that you're including them in that conversation of why that they should be doing these strategies and interventions. But you also need to make sure you develop culturally responsive skills. These interventions and strategies should always match a family's culture and their value system. That's something that's really important, is that we meet these families where they're at.
And lastly, what can we do? What can we provide? We have the beautiful gift of music that makes us unique and engaging for these parents, both for the parents and the child. So we're providing them resources and education of the materials and the different resources that we use, ensuring that everything that we are teaching and modeling can be transferred at home. So research has shown that the best way is by providing a model, being able to engage with the parent and the little one doing that, letting the parent engage with that, then having some discussion about what the parent observed, what some of their concerns were, and then being able to adapt it specifically to their little one, depending on where they are, if they have any delays in any of the areas. So demonstrating, practicing, then discussing so that we can lead to problem solving and demonstrating those adaptations. So essentially, that's it in a nutshell.
So we appreciate you listening to our session today, and we would be happy to take any questions that you might have about typical, atypical development or what you can do in early intervention practices.